Hey everyone, I'm Mitra with Project Echo. So I'll go ahead and share my screen page and pull up your case, and I'll just turn things over to you. Just let me know when you would like me to scroll up or down on your case form. Thank you.
Okay, thanks. So the case I'm going to present today is not super complicated, but there were a couple recommendations that I was going to ask about, and then a couple questions that maybe more just because I'm a medical student, I was hoping to seek some recommendations as to how you would approach this in your future. So I'm going to get to some of these comments after a bit, but if we could just scroll to the HPI, I'm going to start there. So this is a patient I saw with Dr. Todd Smith in Princeton, West Virginia. We saw this patient, I think around the 11th of March. She's a 54-year-old white female. She came to the clinic just for a routine office visit. She was reporting some generalized fatigue, but otherwise she was kind of doing pretty well. I'm going to ask mostly today about recommendations about her type 2 diabetes, about her other comorbidities include a history of hypothyroidism, hypertension, hyperlipidemia, PCOS, morbid obesity, anxiety, depression, as well as a couple deficiencies and a history of yeast infection. So since the last time we saw our patient, which was last July, she had underwent a cardiac stress test for some chest pain, and it was indicating some mild reversibility or ischemia of the anterior wall, as well as some mild reversibility and ischemia of the inferior lateral wall of the left ventricle, and she was placed on 40 milligrams of rosuvastatin by the cardiologist at that time. And then also, since we've seen her last, her husband actually had started undergoing some dialysis, and so she's been struggling at home trying to care for him. It has required a lot of time, and she's not been able to prioritize her health in this time, so it's been really stressful for her. But in that time, she's also occasionally checks her sugars. It's very irregular. Whenever she thinks they're going to be high, she's not really checking them as often. But she's reporting an average glucose around 200 from the readings that she's seeing, but that's also when she's checking them when she thinks they're going to be a little better. Her current diabetic management consists of 2 5-milligram tablets of glyburide twice a day, as well as the sitagliptin metformin combo pill at 50 to 500 milligrams twice a day as well. At the last visit in July, we attempted starting 12 units of Basaglar daily. However, at this appointment, she admitted to not taking that medication. She's really, really afraid of the needles, and so she wasn't able to administer the Basaglar in the last 6 months. Previously, we've tried dulaglutide. We tried the weekly injections, but again, we tried that over the course of about a year, but she really could not take them consistently because she has this deep fear of the injections. We also had attempted dapagliflozin, but at that time her insurance wasn't able to cover it. We provided her some samples in the office as long as we could. However, she was getting some yeast infections at that time, so we kind of discontinued that as well. And then otherwise, she's married. She works as a secretary in a hospital setting. She's a former smoker, and she doesn't use any other substances. So like I said previously, that is her list of her comorbidities. And upon this exam, we had done some lab work before she came in. Her labs were drawn on the 11th. We saw her they were drawn on the 9th, and we saw her on the 11th. They did indicate an elevated glucose. Her GFR is reduced. However, her creatinine and GFR are pretty consistent with labs drawn previously. She is on some kidney protective medication. She's on an ARB. Her lab also suggested that her A1C was 11.9 at this time. In the history that she's been in the practice, her lowest A1C was 7.8, and that was in 2015. But since then, they have been consistently rising. Her last A1C in May of last year was 11.3. And so she has definitely had consistently just rising and elevated A1Cs that have not been able to be better controlled. At this visit, her T4 has been elevated and her TSH was decreased. Her lipid panel was generally actually okay, and then her magnesium still remains low at 1.7. So I had mentioned earlier, her diabetic regimen is currently the 2 5 milligram tablets of Glyburide twice a day. She's taking the combo pill of sitagliptin, metformin twice a day. And then we attempted Basaglar at the last visit, but because she wasn't able to take it, we thought that we might start empagliflozin. That's what we had prescribed as of March 11th. With her recent cardiac history, it seemed like this could be helpful. However, she did already try flozin in the past and was not super successful with that, but this one appeared that the insurance might cover it, and so we thought it might be worth trying again. And then her other medications here are as listed. The only one that we had changed at this visit was the Synthroid because of her TSH and T4 levels changing. We had decreased her dose to 125 micrograms instead of 137. So our questions today, if we could scroll back up to the comment section. Our questions mostly revolve around with the attempted coverage with the metformin, the sulfonylurea, and the DPP4 inhibitor. She's not really seeing great sugar control. We attempted some insulin use, but she really is super afraid of using insulin and the injections themselves. She's had this recent cardiovascular evaluation. We want to start the empagliflozin in the mornings. Would you have any other recommendations? She is having difficulty making any lifestyle modifications at this time, just because she has so much time committed to her husband's current care, and she can't really leave much of the area because she has to return to his visits a lot. So she has limitations currently with what she can do outside of the Princeton area. And then just as a couple other questions, because she has had the history of the yeast infections with the dapagliflozin, is there any chance that she might not be able to tolerate the empagliflozin? I'm not really sure if that is a side effect that if it's noticed with one medication within the class, if it would be likely to reoccur with all medications in the class. And if she does fail this, what would you move towards? She can't tolerate the SGLT2 inhibitor.
All right, well, first and foremost, thank you so much, Paige. That was an awesome case presentation, and we truly appreciate your time presenting it and putting it together and everything, so thank you. Before we jump into any feedback and recommendations to the questions and comments that Paige listed for us, did anyone have any clarifying questions for Paige about the case? Feel free to chime in or chat in, I can read it out.
Paige, I just have one more question about her GFR. What was her most recent GFR?
The one listed on the labs today, or labs from this month?
Yeah, that'd be great.
It was 55.
Great. Okay, that helps.
Sure thing.
And I'm more than happy to pull the case back up as well. If anyone needs to refer back to it or look through the comments, just let me know. And any recommendations or feedback for Paige and the case?
Can you pull the case back up?
I have so many recommendations.
Okay.
I think that we could kind of just talk about it. And if anybody wants to chime in, just let me know. So, Paige, first of all, I think you did such a phenomenal job of presenting a really complicated patient. So kudos to you, like excellent, well-organized H&P and presentation, good assessment plan. And I think your questions were really excellent as well. So great job. I think that in the patient's history, you know, there are some things that I want to help you to define and pick out when you see a patient that will alert you that a patient's going to have severe insulin resistance. And so one of those things that you mentioned, along with hyperlipidemia, hypertension, she had PCOS or polycystic ovarian syndrome. And in females, we know that that carries a much higher risk of insulin resistance and difficult to treat diabetes. And also it enhanced and elevated cardiovascular risk. Women with PCOS in the long term have a much higher risk of cardiovascular death. And that's because there's an abnormal pulsatile signal from the pituitary gland that creates, in men and women, we both have estrogen and testosterone. And in females, the typical milieu is that, women typically have more estrogen to their testosterone ratio. But when we talk about polycystic ovarian syndrome, that changes. There is an elevation of testosterone to estrogen. And what that does is it raises their cardiovascular risk. So I am very pleased that she recently went on a statin because she is at a very high risk for coronary artery disease. We know that she did have coronary artery disease, but she's at a higher risk of cardiovascular death simply because she has type 2 diabetes, but also because of her polycystic ovarian syndrome. And so a tool that we use in clinic to calculate someone's cardiovascular risk is the American Cardiology Cardiovascular Risk Calculator. And what that does is we import the patient's age, their sex, their systolic, diastolic pressures, their most recent cholesterol levels, their total, their HDL, if they're a smoker, which I believe you said she was a smoker at some point. And
yeah,
so
she's a former smoker. She quit about 10 years ago, but still had a 15 pack-year history, 15 to 25 pack-year history.
So that's included in the cardiovascular risk assessment. And also if they have diabetes, and it spits out a number for us. And if that 10-year risk number is greater than 7.5%, it will give you advice and guidelines on the statin that you can use, whether it's a mild, moderate, or high intensity statin, if the patient should be on aspirin, what their current blood pressure targets are. And so I think that's a really good tool for you to just play around with, after we get off today or when you have time to import her settings in there. But I can tell you right now that type 2, so any patient with diabetes greater than 40, the recommendation is to consider statin therapy and for them to have a really good reason not to be on a statin if they're greater than 40 with diabetes. So play with that tool, but I'm glad she's on the statin now. So we know that she's at a really high risk for cardiovascular disease. And I'm happy to hear that you had tried both the drugs that we know help with cardiovascular disease. So specifically for coronary artery disease, the toolbox of drugs that's better is the GLP-1 receptor agonists. Those are drugs like Victoza, Trulicity, Ozempic. Victoza is once a day. The Trulicity and Ozempic are once a week injections. You mentioned she has a fear of injections, and in patients that have expressed that to me, some of the ways around that are I've had them come into clinic and we have a demo pen that you can, I'm grabbing some of my supplies here. We have a demo pen that you can show them and walk them through injections. Sometimes they have family members that are willing to come in and help give that injection once a week. I think that would be an excellent drug for her in the setting of having obesity, coronary artery disease, PCOS. Her A1C is very uncontrolled. And so a GLP-1 receptor agonist, either the Ozempic or the Trulicity, I would try to push that and ask her if she's willing to come into clinic with a family member to do some teaching on how to use the pen and show it to her and see if they can demo it. Our nurses are excellent at showing them the pen and how to inject it, or the family member who could also do that. I think that would be my first step, is to really try to push injections, because not only would a GLP-1 receptor agonist be great for her, but her A1C is 11.9%. And so we know in our algorithms from the American Endocrine Society and the American Diabetes Association that an A1C this high, greater than 9%, warrants injection therapy. It's not my job to torture anybody. I don't like injection. Nobody wants injections. And so I'm very sensitive to the fact, when I have to offer injections as therapy and urgent therapy in this case, she is severely uncontrolled. And so my recommendation is insulin. And I try to be sensitive about that, telling someone, I really believe that she needs 4 shots of insulin a day, which would be before breakfast, lunch, dinner, and then at bedtime. But in being sensitive to our patients in a way to try to compromise is something that you would offer, doing a Basaglar injection. And I would have her come into the clinic and again, try to do that insulin pen teaching because she needs insulin. There is no drug that will lower the A1C to where we need it to be for her, which is less than 7%. There is no pill that will get her A1C down to 7%. Most of the pills and the injectable, the GLP-1 receptor agonists, they're excellent adjuncts to insulin, but they're not as effective as we need a drug to be to lower her A1C from 11.9 down to less than 7%. Insulin is what she needs. And so I wouldn't phrase it, we need to start 4 shots a day. Although in my mind, I think that ultimately that's where we need to get to. But I would ask her to come into the clinic and have diabetes teaching and the pen teaching with her and see if she feels more comfortable. And if a family member needs to be there to do the shots, that is what I would recommend. And I would try to start off with the either Trulicity or Ozempic once a week, and then a shot of basal insulin like you were doing once a day. The pills, you have her on metformin, and it sounds like her dose, it was 500 twice a day. Is that correct?
Yes.
Yeah. So her GFR will allow you to go up on that to the maximum dose of metformin. So, historically metformin was guided based upon creatinine, but that's old. We use the GFR to guide metformin therapy and the dose of metformin. And so if a patient's GFR is between 30 and 45, we can give half of the dose of metformin. And it's not recommended in that time period to start metformin. So if they're on it already, you can lower the dose to 50% of what it should be. If the GFR is greater than 45, you can use the maximum dose of metformin and just follow their kidney function and make sure that it doesn't fall below 30. Okay. So I would recommend maxing out her metformin. I often don't use combination drugs because of cost and because it doesn't allow you to exercise the ability to increase to maximum doses as easily as it does with individual drugs. And so my recommendation would be I'll get to the glyburide in a minute, but my recommendation would be to split that and write metformin separately and max out the dose to 1,000 twice a day. The glyburide. So we can talk about sulfonylureas now. That class of drugs is cheap. It's old. Patients who have no other option is where I use that. It predisposes people to low blood sugar, especially in the setting of CKD, which she has. And it also causes hunger and weight gain. It's not a drug that I prescribe often. It's a drug that I typically try to get off of the patient's list. It's usually a last case resort. So I don't recommend the glyburide. I would recommend discontinuing it, bumping up her metformin, and trying to get her on a GLP-1 receptor agonist with a shot of basal insulin. And if she says, you know what, I just can't do the shots, I would reattempt an SGLT2 inhibitor, which is your class, it's either empagliflozin or Giardians, that's Invokana or canagliflozin, or dapagliflozin or Farxiga. Mm-hmm. Those drugs are really great because they act like diuretics. They have a natriuresis effect. So they promote excretion of glucose through the urine. And it's really helpful for heart failure patients, which she doesn't have. But nonetheless, it's great for blood pressure, which you told me she does have. It's great for A1C lowering. But the risk is when you're pulling sugar into your urine, you're bound to have more urinary tract and yeast infections because, infections typically gravitate toward, high sugar. That's why patients with diabetes have a higher risk for infections. And so I will point out that patients with diabetes already have a higher risk of a urinary tract and yeast infection, even without your SGLT2 inhibitors, just at their baseline, they have a higher risk of urinary tract and yeast infections. Typically, we stop the SGLT2 inhibitor if they get more than 2 infections in a year, or if they get 1 severe infection. So, a septic event related to urinary tract infection or pyelo, we obviously stop the SGLT2 inhibitor. And so the thing about those drugs is if their sugars are wildly uncontrolled, which hers are, right? Her A1C is 11. Her risk of having a urinary tract or a yeast infection and going to the bathroom constantly is much higher because her sugars are uncontrolled. So that's why I would address lowering her sugars first with the metformin bump up and with the insulin and the potential GLP-1 receptor shot first before I would attend to the SGLT2 inhibitor. Because if you lower her sugars, she's not going to go to the bathroom as much because she's not going to have as much sugar exiting her into her urine, and she'll be at a lower risk for that urinary tract yeast infection and more likely to continue the drug with compliance because it makes people urinate more frequently when their sugars are super uncontrolled. And so, I would go that route. I think that when you have her come into the clinic, an important piece of teaching would also be a continuous glucose monitor. A lot of my patients that are afraid of needles will still do them when the nurse in the clinic puts it on. And so I have a demo here I can show you. So this is just one type of continuous glucose monitors. There's also a Dexcom. This is the newest generation of it's called a Freestyle Libre 2 system, the newer one. The drawback of the number 2 system is that there's still not like a cell phone app like there are on the other kinds of continuous glucose monitors.
Okay.
I'm clumsy and I dropped it. Give me 1 second. Okay, so this is what the inserter looks like. And I apologize because I wore the continuous glucose on the monitor on myself, so I don't have that to show you. But the way it works is you simply dial in, twist it on, and your nurses can help with this. And then you'll see that the little inserter that looks like this, it's about a quarter size.
Okay.
That white thing, that is worn on the back of the arm. And the nurse or her family member could push this onto the back of her arm. And for 1 second, it's uncomfortable. But after that, she would have that little sensor on her arm that can last for a 2-week time period so that she can try to avoid doing a finger stick. And the way that she would check her blood sugar then is, this is called a reader. Can you see it okay? Okay, so the way it works is you simply just go like this over where your sensor is that sits on the back of the arm, and it instantly checks your blood sugar. And so that's a really nice alternative to somebody who is afraid of needles because, it's a one-time insertion, and they won't see a needle here. They'll see like a little catheter looking tube. So it's not a needle, and there's not a needle that sits in the arm. And she can even come to the clinic. We have patients patients with even MR, severe debilitation who come to clinic, and our nurses change out their sites and can help with continuous glucose monitor insulin pump sites. So that's an option for her to be able to check her blood sugars without the continued pain of doing a finger stick. And again, that needs changed out every 2 weeks. Once you have the reader, which is about $75, you don't have to replace this piece. And a lot of the times Freestyle Libre we have tons of samples of readers. And so we can give these in our clinic. But what they have to buy every month, if their insurance doesn't cover it, would be the little sensor that she would change out every 2 weeks.
Thank you.
Any questions about that?
No, that is super helpful. And I think like with definitely some of your recommendations, they were things that we had tried and it wasn't like super successful. Like she wasn't able to take them. So it is helpful to see how you can encourage like the Trulicity, like with bringing her into the office and seeing if that would be a better way to get her started to maybe trying to take that weekly, because she definitely is very out of control.
Yeah, and I've also had to refer some of my patients with really severely uncontrolled diabetes for counseling and coping strategies for fear of needles. And so I've referred to psychology and also like psychotherapy for help with their fear to try to overcome that. And so that is an option too. I think that needles are not something, it's not a pleasant experience. And so the obstacles that she had, we just have to figure them out and kind of try to always work around them and figure out how to make her, best feel comfortable. But I think explaining to her that there is no drug on the market that can get her A1C, that's never been proven to get an A1C from 11.9% down to less than 7. And so insulin is what we need. So a shot of insulin a day, the basal insulin, if she doesn't do anything else, I would highly recommend just starting with that.
Thank you.
Sure.
Thank you, Dr. G, for all that great feedback and recommendations. I did also want to direct everyone's attention to the chat. Janet, I noticed you had chatted in a question about metformin and then some recommendations as well about educating the patient. I didn't know if you wanted to maybe elaborate on that and maybe ask those to the group.
Mitra, can I interrupt for 1 second? There's a thought that I didn't finish and I meant to also mention. Paige, you mentioned that she was on sitagliptin metformin combo pill.
Yes.
Right? So that is, sitagliptin is a DPP4 inhibitor. It's an incretin drug. So when you begin the Trulicity or the Ozempic, the sitagliptin should be held. Because we don't combine incretin therapy for an elevated risk of pancreatitis.
Right.
And so if she's willing to do Trulicity or Ozempic, which has that cardiovascular protection, then you would stop the sitagliptin, which does not have the cardiovascular protection. Even though they're both incretin drugs, the gliptins are orals. They don't have cardiovascular protection benefits at this time. The GLP-1 receptor agonist incretin, that's an injection, does have the benefit. That's why I would transition her from the sitagliptin to the Ozempic or Trulicity. Thanks for letting me interrupt, Mitra.
Yeah, no, not at all. Thank you so much. We appreciate you taking the time for all that great feedback. Dr. Pollywell, sorry, I noticed you unmuted, but no worries at all. Janet, I saw that you had chatted in. Did you want to elaborate on your question and that recommendation you had?
Oh, I keep writing.
No worries at all. I love it.
So I had the same thought about the metformin wasn't maxed, and that unless she had an intolerance to max metformin, that would be a good place to go to help with her insulin resistance. And then I thought about her history of yeast infections and wondering how much advising she'd received regarding personal hygiene steps that might help reduce the risk of yeast infections while on an SGLT2. So those were thoughts. And then more recently, my last comment was, what is the lady drinking as a beverage? Because if she's drinking regular sodas frequently, you might impact your glucose tremendously by having your switch to sugar-free beverage.
Thank you.
I'm all ears for any other feedback from you all.
I have a question for Dr. Jennifer. I mean, you mentioned about that Libra 2. Now, is there any particular glucose monitoring which most of the insurance are covering? Is there one particular? Because I have had problem with insurance.
Don't we all? I wish I had a magic answer and a solution for insurance, but I keep I can send it to you guys. I keep the recommendations for here. Let me show you. You're probably not going to be able to see it because it's in small print in my office here, but continuous glucose monitors are a very expensive way to monitor blood sugar. Although in our patients with neuropathy or fear of needles or elderly patients, you know, I feel like every single patient with diabetes should have access to them. And so I'm trying to do research to try to change the policies on continuous glucose monitors, but that's a can of worms for another day. And so for coverage, I keep these in my office, and these are the criteria. This is the state of West Virginia, the Department of Health and Human Services. And this is what they cover for CGMs. This is Medicare's guidelines, which I'd be happy to send these to Mitra to distribute to everybody, but it's very dependent on the patient's insurance. And a lot of the times insurance companies force the patient to do 4 checks a day before meals and at bedtime and require that anywhere from 6 weeks to 3 months before they'll supply a continuous glucose monitor. And even then, it gets challenging for them to continue to renew all the sensors. I think that in time that will get better, but for right now, we do a ton of prior authorization. Our nurses are on 30 to 60 minutes per case for prior auths to get these things covered. And so I think our clinic is really lucky because we're equipped with diabetes nurses who do that all day, every day. Some solutions would be samples are a good way to just start and see if it really helps the patient. So the Libre 2 system, they've dropped samples like the reader itself and then the sensors to your office. If you have a patient that, you know, really wants to try it, but it can't get covered, that's a trick that I typically will give out a couple sensors to get them through, because the sensors every 2 weeks. Say your patient's on steroids or, you know, their blood sugar is evolving rapidly. Sometimes I'll just give out 2 or 3 sensors to try to get them a few weeks. But the criteria is difficult, and getting the coverage for CGMs is difficult. And I don't have an easy solution around that. A lot of the times it's just making sure they check, making sure in your office note you put patient, if they are, I mean, you never want to document obviously anything that's false, but you know, if the patient is checking 4 times a day before meals and at bedtime, it needs to be visible in the note, because insurance goes back and looks at that note and they determine their criteria based on, is your patient checking their sugar 4 times a day? And if they're not, why? So if they're not, put in your office note, patient has severe neuropathy, patient has diabetic retinopathy, cannot see to check their blood sugar, doesn't have dexterity to check it. You know, there's tons of reasons why people can't check their sugar. So you document all of that, because insurance is looking at the blood glucose testing specifically when they're approving these CGMs.
Thank you. And one more thing, you said, how much, do you know how much the sensor cost?
Yeah, I do. So the price changes slightly from month to month, but this is about $75. But the good thing is kind of like, if you think about the meters and the strips, you know how we give out meter. Well, I don't know about your clinic, but our clinic, we get tons of meters. Like, we can hand out the meter, but the really costly piece of diabetes care is the strip, right? So that's the same idea with the continuous glucose monitor. So what we have is a ton of these. These are $75 a piece, but we have a lot of these. The costly piece is trying to get this renewed every month. And so these per month, it's about $75 as well. We usually price that through like the apps, like the Needy Meds apps and the apps that you can find to compare prices throughout all of your different pharmacies in your area. And our nurses help with that. But roughly $75 for the sensors.
Yeah, yeah. Thank you. And for the case going on for the fear of the needle, I mean, what I have done is that I'm fortunate to get some samples of Ozempic and Trulicity. So usually when I talk to the patient about this, I give them the first dose here. And I ask them, can you give me just one opportunity to give you one-time injection here? And most of the time, when they had one time, they not only felt good, but they have also told me that their sugars is much better control for 24 hours. So that made them choose it. And lately, what I'm finding in my elderly patients, like they like it, they have to take once in a week injection rather than even taking metformin twice a day daily with all the other medicines they are taking. And I have a peace of mind of not ruining their kidneys or they having blood sugar of less than 60, which always terrifies me.
Thank you. That is super helpful.
Yeah, I think that's great advice. I think that, you know, in our elderly population, I've struggled a lot too with patients that can't, you know, just this morning in my clinic, patient at home, she has severe neuropathy, retinopathy, and she can't check her sugars. And she has an allergy to the tape from the continuous glucose monitor I've put on her, which is rare. She can't use a Dexcom or a Libre system. And so then, you know, I asked for social work to immediately see her to try to get a home health aide, you know, they could even go into the house or home health nurse, even if they could come in and inject the GLP-1 receptor drug once a week. Something is better than nothing.
Absolutely.
Thank you all so much for this great discussion and the questions and everything. Paige, did you have any other questions you wanted to have addressed about the case that you presented?
I think that I've been very fortunate. I think that you guys have provided me with a lot of really helpful feedback, and I appreciate the opportunity to learn from you guys. So thank you so much for helping me out, and hopefully this will help our patient back here in the clinic. But I really do appreciate the recommendations that you guys have made. This will be awesome.
That's awesome.
Paige,
Yeah, no.
I hope to see you coming to Endocrine Clinic to work with us.
Thank you. I'm very excited too.
I loved your case.
question.
Thank you so much for presenting. It was great.
Thank you.
And Paige, I'm going to have those recommendations for you. I will email back your format and have those recommendations that everybody spoke about today too.
Thank you.
Of course.
Janet, was there something you wanted to add as well?
Well, I wondered if Dr. G would answer this thought or this question. Is it possible this patient may only need insulin for a few months and then might actually get adequate control without the insulin down the road? What's your perspective?
Thanks, Janet. You guys have all had really great questions. So the natural history of type 2 diabetes is that is a progressively worsening disease, right? Mm-hmm. So in patients that say that she suddenly stopped drinking sugar beverages, she goes to the gym every day, she's eating salads, doing all the right things and modifying all of her risk factors. There's two things at play in her case that make me feel that it's going to progressively worsen and she needs intensive drug support with insulin. Those things are the fact that we know diabetes progressively worsens. So once we burn out beta cells, we don't regenerate them. And that's the course of the disease in all of our patients. We can modify things like our diet, our exercise, environmental things, but you cannot modify the beta cells. There's no drugs. There's some data that the TZD drugs may have some protective benefit to a beta cell, but we have nothing in 2021 that saves the beta cells from diabetes attacking it and burning out the beta cell over time. So her disease is likely to continue worsening based upon the natural history itself. Then we add on polycystic ovarian syndrome, PCOS. It is incredibly hard for women to lose weight and change because that internal hormonal milieu, she has a higher amount of testosterone to estrogen. So she's fighting an uphill battle in controlling her sugars and controlling her weight. Women with PCOS have a tremendously difficult time losing weight. That's why I think that the GLP-1 receptor agonist would also, because of her coronary artery disease, but also because, with weight and PCOS, it'd be a great drug for her. Women that have PCOS have a tremendous amount. They have the hardest time losing weight because of the hormonal disturbance. So in some patients, like say a patient has like steroid-induced hyperglycemia, they're on prednisone for a transplant, or they're on prednisone because of sarcoid or bronchitis or something. In those patients, you can say, you know what, there is some degree of reversibility. Or patients who develop prediabetes or diabetes and they work really hard to reverse the diabetes. Sometimes you can see reversibility, but in her case, the degree of her hyperglycemia with her underlying conditions, it's not likely.
Thank you.
Sure.
Any other questions or comments?
I will add that bariatric surgery, I didn't mention that, but bariatric surgery, it's very invasive, but it is a way to control many of the conditions that we see in my clinic specifically, and in this patient, hypertension, hyperlipidemia, blood sugar control, sleep apnea. And so it is an option that is reserved for patients who really have a hard time with dietary modification, lifestyle changes. So that is an option. And now the most common surgery is the sleeve, and that can take some of the burden off. It does lend to insulin sensitivity. But again, it's invasive and, kind of I shouldn't say last case resort, but, something to consider.
Thank you so much, Dr. Giordano.
Absolutely.
So we do have about 5 minutes left. I can give you guys 5 minutes back to your day, or I don't want to cut it short if there are more discussions. It's been such a great session. I thank you all so much. And as always, if there are any questions or comments after the fact that you think of, just shoot me an email. I'll make sure to have them addressed. And Dr. G, I know you had some of those resources that you wanted to send my way. So anytime you get a chance, just email me those and I'll make sure to attach it in the recap email for everyone to have. All right, guys. Well, I'm gonna just go into announcements then. My only announcement for today really is that our next session will be on April 14th. And Dr. Perny is going to discuss goiter management. So keep an eye out for that reminder. Big thank you to Paige for that awesome case presentation. We get so excited when we get a case presentation, especially from a CARS student. So we wish you all the best in your future endeavors. You're more than welcome to continue joining the sessions, submitting cases if you want to. But big thank you to you, and thank you all for the great questions, comments, discussions. And Dr. G, can't thank you enough for joining as the hub side as well and giving such great feedback and recommendations as always. So thank you guys so much, and we'll see you next time. Bye.
Thank you, everybody.
Hi, thanks.